Thank you, Hamid, and take it away. Thank you.
Thank you very much for the invitation to give a lecture about fatigue and fatigability after stroke. My name is Hamid Ghatan, and I'm MD working at Uppsala University Hospital. I also have a PhD in cognitive neuroscience. I'm going to hold this lecture related to a long time neglected problem for stroke patients. So I'll guide you through this presentation, and if there are any questions, I think we take them in the end of my presentation. Starting with stroke, we all know that stroke is a disease, a condition that affects the circulation to the brain. You can have plugs that impairs circulation to different parts of the brain, or you can have lesions in the blood vessels that creates bleedings, hemorrhages in the brain. So usually the view of the brain from an acute perspective is like a tree with these vessels and how the circulation of the brain is affected. The important thing to consider is that a stroke, a disturbance in the circulation of the brain, is not just a short impact. It's something that triggers mechanisms that can go on for a very long time after you have the acute stroke. And of course, this affects function and disability. As an example, I have this presentation in this image illustrating the dynamics in an ischemic, an area that is affected by a stroke. This is a lesion in the left hemisphere that is at the first one day after impact. You see some changes on the radiology scan of the brain, but then you see a continuous change during the first 4 weeks. And of course, this has consequences for the symptoms that the patient displays. So it's not a static, it's very dynamic, an ischemic event or a hemorrhage. This is an example of a hemorrhage in the brain. We see the blood clot, and of course the volume of the blood clot affects the functions depending on where it's localized. But then you have a resorption of the fluid in the blood clot that in the end you see much smaller lesion. So you have a dynamic there as well, affecting function. But this is a traditional view of a stroke patient in the acute setting, and we have, at least in Sweden, we have seen a tremendous development both in preventive measures to prevent stroke, as well as the acute interaction with where you treat the thrombosis to minimize the consequences of an acute stroke impact. But looking at it from a biological point of view, when you have an injury, you have these domino effect with different stages affecting the nerve cells, affecting the glia cells. You can trigger a programmed cell death that we call apoptosis. And you also see this neuroinflammation developing, and then these kind of chronic changes that has been demonstrated up to a year after an acute impact due to a stroke. So it's a very dynamic process, and this image I think pinpoints the importance for us in a rehabilitation setting. When should we start interacting with the patient, and with what intensity should we do it, and the duration of the stimulation of the system to optimize recovery. In rehabilitation, focus has been addressing a lot depending on lesion location, what kinds of functions are affected, and what kind of impairments, disabilities do we see. So a lot of the methodology has been addressing if you have a left hemisphere lesion, you might it might affect language skills. It might affect the motor function or sensation from the right side of the body. If you have a right hemisphere lesion, it might affect motor function and sensation from the left side of the body. It might affect your skills in spatial awareness. So patients can, for instance, in a lesion here in the inferior parietal lobe, display neglect, hemi-inattention, as we call it in the medical field. So a lot of rehabilitation has been so far addressing a lot of these specific symptoms related to lesion location. And when it comes to stroke patients, it's quite easy to see the correlation between lesion location and the symptoms functions that patients show, or the functions that are affected. However, this localization perspective is not according to the development in cognitive neuroscience, where we know that the brain is a dynamic plastic system with different regions interacting in functional networks. So a lesion in the left hemisphere affecting motor outcome in language is not only affecting language skill in expressing yourself in your language, it might affect working memory as well, your short-term memory functions. It might affect motivation. It might affect mood as well. So this localization perspective is still a limitation in the approach addressing the consequences of a brain injury. I will give these two slides as this slide as an example. The left um, picture illustrates a lesion in the left hemisphere, and we can interpret that most probably the patient has impairments in language skills, motor function, and sensation. These are the specific symptoms that the patient displayed based on this lesion location. This image to the right illustrates a lesion in the right hemisphere close to the basal ganglia, central dense structures with very dense neurons. This patient, the specific symptoms that this patient demonstrates is more of a memory problem related to working memory, visuospatial skills. So two examples, and looking at workability, this patient is working in the patient's ordinary function 50%. This patient is not able to work at all, and I will get back to that later, why. So we can see that the size of the lesion doesn't affect workability, for instance. And then we have also the dynamics in this plastic organ. We have the reorganization after a brain injury. We know a lot about how the neurons and the glia cells are affected, and also the relationship with recovery and also the response, for instance, at the neuronal level, or the density of dendrite spines, etc. So there's a lot of research relating to this at a cellular level. And then the image to the right, illustrates the local in the local area in the brain, in the cortex, for instance. You have you can call it a geography where these neurons interact with each other. And we know in a normal setting, depending on automaticity, that you have a change in this local geography. And there is a lot of research now that also shows how activity changes in the local area in relationship to a lesion. So you have dynamics at the cellular level, you have dynamics at the local level, and finally, you have also a dynamic at the system level, which shows this image just shows the increased activity with time related to function. But this illustrates also the opposite effect, that also when patients recover function, you can actually see a decrease in these functional networks. So you have a dynamic system that is plastic. And so far we have been addressing a lot the specificity of lesion location and the functions that have been affected and the symptoms that the patient display. And we know from research that intensity of the stimulation after brain injury is important for recovery. But the critical question there is whether this intense stimulation should be at an optimal or a maximal level. And I think this is crucial because there is a lot of research that shows that this plasticity in the brain that I've illustrated here is stress sensitive. So how intense, when should rehabilitation be initiated? With what intensity should it be performed? And how long should it continue? That's some of the key questions that we need to address from a scientific point of view, and continue to grow, to increase our knowledge about the dynamic changes after an acute event where the circulation to the brain has been affected. At the same time, besides these specific symptoms, patients with conditions also display non-specific symptoms. I have just here set up examples like irritability, attention problems, memory problems, and fatigue that cannot be related to a specific lesion location. And these symptoms are common among many different diseases and conditions. So they are very unspecific, non-specific. And the challenge with these non-specific symptoms, especially fatigue, has been to define it. There are many definitions. And I think that this has been one of the main reasons why we have neglected fatigue for a very long time when it comes to brain injury and brain injury rehabilitation. But during the last 10 years, there has been a growing interest regarding the fatigue post-stroke. I mean, back in the 90s when I was working with stroke patients, 50% of the patients I was treating, they were treated with antidepressants. So already then, back in the 90s, the question was, is the depression that we see among stroke patients post-stroke, is that some sort of fatigue-related mood disorder? And today, there is a common agreement that fatigue needs to be considered when it comes to brain injury as well as stroke. And the definition is that it affects the energy level that the patient experiences. The patients have an increased need for sleep. They have this fatigability effect that they display. They need to rest. It's very unpredictable for the patient, and the patient is stress sensitive. As I said, it's a very neglected problem. However, within neurology, for instance, it's been well known that patients with multiple sclerosis, a neurological condition, displays fatigue. Patients with Parkinson's disease have fatigue. Patients with cancer diseases, 80% of patients with cancer in research studies displays a fatigue that is not normal. And looking at the studies about how common it is among brain injury patients, as I said, it has been very underestimated. We can see that among stroke patients, depending on the studies, it's between 30 to 70% of patients that have this problem with fatigue. Traumatic brain injury, 50 to 70%. Subarachnoid hemorrhages, 50%, 56% of them display this problem with fatigue. So it has to be taken into consideration. Why? Well, because it has a huge impact. There's a number of studies now that shows how fatigue is affecting the patient after a brain injury. It affects their quality of life. It affects their mood. It affects the rehabilitation. It affects recovery when it comes to function, level of disability and impairment. It affects workability, and it also creates social conflicts. So I would say from back in the 90s, where I was treating stroke patients with post-stroke depressions, today the main focus is to coach patients in handling the fatigue and the fatigability that they display. There are some studies, Schoenberger, for instance, who have shown that lesion location, there is a correlation between lesion location and fatigue in the medial prefrontal cortex, in the anterior cingulate cortex, in basal ganglia, in the limbic system, and also in the brainstem. Lesions there have been correlated with fatigue. This image displays this patient I showed you earlier with this lesion in the right hemisphere. This patient can withhold activity for 15 minutes and then it's log off. The patient displays symptoms of fatigue, attention problems, memory problems, and has great difficulty in interacting with the environment. This patient to the right has a small lesion in the left adjacent to the basal ganglia. This patient has a capacity to be active, and we cannot find any specific symptoms during 20 minutes. But if you pass 20 minutes, the patient is affected by fatigue and displays attention problems, memory problems, etc. So based on this, it's very important to address both the specific symptoms as well as the non-specific symptoms. And the explanations for fatigue, the cause for fatigue, I've just to illustrate the complexity of the question, is that there are many possible explanations for fatigue post-stroke. In the scientific literature today, it's related to the reorganization of the neural networks, that the new networks that have been developed are more demanding to maintain active. So it's sort of an energy perspective that it needs, the brain needs more energy to withhold activity in the reorganized neural networks. However, if you look at the scientific literature, there are many other plausible explanations for fatigue. And I think that in the subacute phase, there is most probably some sort of inflammation in the brain after post-stroke. And the interesting thing is that when I meet patients that have gone through the acute treatment with thrombolysis and thrombectomy, where you try to dissolve the thrombosis or extract the thrombosis from the vessel, these patients can recover function and they don't show any specific symptoms within 24 hours after treatment. But they continue to have problems with non-specific symptoms and especially fatigue and fatigability. So in the perspective of waiting for the more profound scientific explanations for whether it's the lymphatic system that might have been affected, or whether it's inflammation or whatever, we need to handle it from a clinical perspective. And handling it from a clinical perspective, this image should illustrate the clinical approach. First of all, I use assessment scales, and I don't use that are validated for stroke, post-stroke fatigue. And I'm not using one, I'm using two, because there are similarities, but there are also differences in these assessment scales. And I also use the visual analog scale to measure fatigue. For instance, when I have a consultation with a patient, when the meeting starts and then when the meeting is over, to look at the dynamic changes in fatigue that the patient experiences. But so the research field has been addressing the fatigue. Fatigability is more of a dynamic perspective, that the patient might have a buffer where they can maintain function before it deteriorates. So it's more of a time-dependent ability. And there in the clinical setting, the patient needs to monitor themselves and assess themselves from an intellectual point of view, from an emotional point of view, from a physical point of view, and also from a social interaction point of view, and try to monitor the time that they can maintain function before their functions deteriorate. And also this is something for the team to monitor. For instance, if the patient has an impaired function in a hand or an arm, how long can the patient be active before we start seeing impaired function in the motor functions in the affected hand or arm? So based on the assessment with these scales and the self-monitoring and the team's monitoring, we try to create a structure for the patient where the patient should stabilize the condition, identify factors that are affecting their stability, both from the exterior in the surrounding as well as interior, sleep problems, spasticity, pain. These are demanding things that affects their stability. And then when they have monitored the extent of their capacity to be active intellectually, emotionally, physically, and social, we try to create a structure for the patient where they should be active at an optimal level. And then they should stop before they pass the threshold where the symptoms increase. This is a method which is in the literature and also in the clinical setting called pacing. So the patient is coached in being active at intervals, and where they are active and then they are resting, so they recover energy to the system. And based on this, when you get this effect, that the patient has this stability and has this structure where they are aware of that they can maintain attention for 30 minutes, being a high intensity intellectual work or activity, or social interaction, low intensity, an hour, high intensity, 15 minutes. When they maintain activity within their capacity, with time, you see that their capacity increases and their need to rest decreases. So based on that, it's a way of preventing stressing the recovery after a brain injury, since we know from basic research a lot about how stress affects synaptic plasticity, how the neurons are affected, even the stem cell regeneration in the hippocampus is affected by stress. This is a way of avoiding stressing the recovery after a brain injury. So in the long run, I can have patients 4 years after stroke that are not displaying any fatigue using these scales, but they have this fatigability effect that they can maintain activity, motor activity, for 20 minutes, and then you see functions deteriorating. So in the long run, the challenge for us is also to know at what level patients should be set at to be sustainable in the long run. Because I've been working so many years, and I've been working with young patients with stroke. In the long run, you can have this cognitive decline, or you can have deterioration of function. And the key question there is, what level should you be active on to have a so sustainable functional level as possible in the long run? I think this is also a question for us to address for the future. So should patients be forced to return to work? And in Sweden, they need to go back to work 100%. They might not have the capacity because they have this fatigability effect that actually impairs, and with time it might have severe consequences. So my conclusion, based on working with the stroke rehabilitation since the early 90s, is that today I don't see these post-stroke depressions in the same extent. And I don't think it's due to the acute treatment of stroke patients. I think it's due to that we are much more aware of and coaching patients in handling not only the specific symptoms or functional disabilities that they display, but also the non-specific symptoms, fatigue and fatigability. So I think this is a very, very important questions for the future for us to address, to not only with a radiology methodology, understanding the dynamic changes in the brain, but also understanding the more biological dynamics, and not only in the brain, but in the whole of the body, because the body is a complex system. So functions in the brain might be affected by organs in the rest of the body. So we need to have a holistic perspective related to patients in a post-stroke setting. So based on this, I think there's a lot of research going on. So I think that a lot of these questions that I've addressed so far will be answered soon, I hope. But in the meantime, it's very important for us in a clinical setting to be aware of not only the specific symptoms, but also the non-specific symptoms, and take fatigue and fatigability seriously. Thank you very much.
Thank you, Hamid, for your very informative talk. And so I would like to invite everybody now to pose questions. So you can just pose them directly. You don't have to write them down if you have a question. Otherwise, I can kickstart. You mentioned injury to the neurons is very important. No? We have a level of toxicity around the area of stroke. Of the stroke, and so there is a lot of a cascade of events that at the end exactly provoke injuries to neurons, and therefore to their ability. So some die and some others are affected in the typical penumbra. So there is a lot of stuff going on. So and the injuries that the stroke patients may get depends also how wide is this area where the neurons do not die, but also survive badly. Because also there we lose synapses and we lose the ability of a functionality of those neurons. So I'm wondering if this cascade, or this toxic cascade, they will impair energy production, right? Because at the end, all the cells in our body produce energy, and energy is responsible for the way we move and we perform. So I'm wondering whether these toxic effects, this cascade, are responsible also in the long term of the ability of several areas of the brain that are surrounding the stroke to have impaired energy production, and therefore impede somehow the optimal functioning of certain part of the body, like muscle fatigue or mind fatigue or cognitive fatigue. So that maybe it's related to this inability of at the biochemical level of the neurons to go through their production of energy, like so many molecules of ATP. So, the typical energy production really at the molecular level. So I'm wondering if there is any link, any study that exactly pinpoint this issue.
Not to my knowledge. I mean, a lot of attention at the moment is using methods to monitor and display inflammation, neuroinflammation, and we have some breakthroughs in, for instance, in Uppsala, where they have been monitoring not the traditional clinically used assessment factors that somehow relates to inflammation, but actually using a more advanced technique. And there they have shown, at least in acute setting, not after stroke but after traumatic brain injury, that you have this increase of neuroinflammation in the brain tissue, as well as in the compartment of the cerebrovascular system, and you can also monitor it in blood, right? So you have different compartments, and I think that this will be something that will be developed within in the coming 5 years, that we will have tools to better understand the plasticity, the inflammation going on, and how that might affect recovery. But when it comes to energy, energy has been as non-specific as fatigue. So how do you measure fatigue? Yeah, you can energy. One way is to look at metabolism in the brain using SPECT, PET, etc., and MR spectroscopy. But it's too early. I mean, it's still very much at the basic research level. So I think that what will change the clinical setting, at least handling these patients in a recovery after stroke, will be that we will have tools to monitor biology in a better sense. But energy, that I haven't seen that being addressed, because it's so complex. There are so many possible factors. I mean, the whole research field today is addressing neural networks, but looking at the rest, as you said, energy, mitochondria, how are they affected, the circadian rhythm, etc., the biological rhythm. I mean, in a rehabilitation after the acute phase, we try to stabilize the patient at the rehabilitation ward, and in the early phase, it's handling the regulation of the internal organs. It's the circadian rhythm. It's getting the bowel functions to start working, the bladder function to start working, feeding the patient, metabolism, etc. And then the next phase is addressing more the adaptability of the patient in the setting of in rehabilitation. The interesting thing is that in a clinical setting, in the in-ward rehabilitation, we don't see so much fatigue, but we see fatigability effects. So fatigue is something that is shown usually when the patient comes to the outpatient clinic. And that's also interesting, depending on inflammation. Is there some sort of delay in the neuroinflammation affecting the patient? We still don't know that.
So I see a few questions on the chat. Maybe I can read them to you,
read them.
Or you guys prefer to mention it yourself? Like Xavi, one question from you, from Martina.
Okay. So thank you for your talk. I was asking in the chat if you could emphasize on the distinction between fatigue and fatigability, like the definition of this distinction clearer, and if you consider it as being the same process or different processes operating in different time scales. For instance, fatigue more on the short term, referring to muscular and so on, while fatigability operates more on longer time scales.
Yeah, it's a very good question, and fatigue is you assess a number of symptoms that the patient experiences, like sleeping problems with sleep. They need to sleep more or less, etc. So it's a way of monitoring how tired the patient is. Fatigued, and these assessment scales, for instance, mental fatigue, they have thresholds also, that based on the research done, that if the patient gets less points than like fatigue severity scale, which has been used a lot internationally for stroke on stroke patients. The patient needs to score 4 points and above to have a fatigue. I mean, these tools are still crude, I would say, but they somehow monitor the non-specific symptoms in a more general setting than the specificity of the symptoms that we have been addressing so far related to lesion location, right? So fatigability is more of, most patients, they have a capacity to be active until somehow you see a deterioration of function. So it's more of monitoring the extent of time that the patient can be active until functions deteriorate. So in a clinical setting, it's usually black and white. Patients have memory problems or not. Patients have aphasia, language problems or not, right? But in these dynamics, patients can be function from they can have a function with their language for a while, and then they start having problems like finding words, expressing themselves. If they have dysarthria, problems in articulation, you can see that they can communicate for a while, and then you see a deterioration of function, that they have this kind of disturbed articulation. So it's more of monitoring the time extent that the patient can maintain a function before it deteriorates. And they also display non-specific symptoms like irritation or lack of focus of attention, dizziness, etc. And I think this is very interesting because traditionally in the clinical setting, we have been seeing it very much as black and white. You have it or you don't have it. This somehow displays a buffer that they have a capacity to maintain their function before it deteriorates. And I think it's very interesting now with the research related to networks, for instance, top-down regulation of cognitive functions or the emotional regulation, that these networks might somehow the patient with time, you see a deterioration of withholding the activity in these networks, and the patient starts displaying these kind of symptoms. So it's more of seeing a dynamic in the and since you have a reorganization, I think a critical question is, if you have a reorganization that has improved function and the patient can be active with this compensatory plasticity to a certain extent. So should we push them beyond that level, or should we stop them before the functions deteriorate? I think this is crucial, going back to the plasticity and the sensitivity of plasticity in relationship to stress. So fatigability is more of not looking at how tired is the patient, how fatigued is the patient, but actually looking at the timeline. How long can the patient maintain a function before it deteriorates? And that's fatigability. And fatigability has so far mainly been addressed in cardiovascular diseases, especially among heart failure patients. There is a lot of research related to fatigability effects, but within the field of post-stroke rehabilitation so far, the main focus has been fatigue and not so much fatigability. So I find it very, very interesting with the results that you have with the RGS clinic. If you can show fatigability effects when patients that you have included in the studies, whether you see some sort of deterioration of function with time or deterioration in the scoring of their performance, I think it's a very, very, very interesting, and you have the gold mine.
Then in that sense, if I can add just a quick comment on that, and then there are other questions in the chat. So you believe that the duration of the training protocol should be modified according to the fatigability of the patient. So when the function state starts deteriorating, then the question if it has to be right afterwards, if it has to be before, or at what point does this modification
I think that's a
right.
brilliant question from you, and that's something that I've been bouncing with Paul. That this is the question that should sharpen the scientific research and our understanding, because yeah, from a clinical point of view, I try to make the patient stop before they pass the threshold when you see a deterioration of function. But this is a question that I still, because that based on experience, I know that when patients somehow overwork what they're doing in activity, you can see this kind of, they display depressions, or they get these fatigue that increases. And the question is, does it impair recovery? So based on that, I think also based on in which phase the patient is post-stroke, maybe it's we should have it in the early phase, that they should stop before, based from a clinical setting. I know that when patients have recovered back to 75% of normal activity, then they can start pushing their limits. And when they don't need to rest for a longer time after they have pushed the threshold, then I know that they have stabilized at that level and they can take the next step. So based on adaptation, I think this is also a very interesting perspective, but I think we need to address this from a scientific point of view. And you have, I think, some results already.
Okay, thank you.
We have another question about how to deal with your rehabilitation once depression has been confirmed.
Yeah.
Martinas, you want
Yes, exactly. So I wanted to know more about your take on the interaction between, the relationship between depression and fatigue, because depression itself is also associated with many other symptoms, right? Like anhedonia or anxiety and heightened stress levels, which then itself has been associated that people are less willing to participate even in rehabilitation, and are also not very good in self-monitoring or in self-assessing how their capacities are. And I wanted to know, like, how would you go about, or what is your take on how we then should give rehabilitation, or how should we change monitoring to also account for these other, let's say, debilitating aspects that then come with depression?
I think that's also a very good question. And, referring back to the 90s, in Sweden, it was absolutely forbidden to use psychopharmacological drugs on patients with brain injury. I mean, it was a taboo. So I started looking at the research literature in the early 90s, and I saw that back in the 80s, there were studies showing that patients with stroke displayed post-stroke depressions, and they were treated with antidepressant drugs, right? So during the 90s, everybody developed the strategy to use the old drugs like tricyclic antidepressants, and then the SSRI drugs. And the interesting thing was, when you treated a patient with depression post-stroke, you saw recovery as to the depression, but not only that, the interaction with the rehabilitation setting improved. So I started using actually antidepressants as neurostimulation to see whether I could somehow promote recovery post-stroke. And there is some research, as you know, that it affects the stem cells regeneration in the hippocampus, for instance. So, and it can even be preventive to use these kind of drugs. But for me, from a clinical point of view, I find it very interesting that today I don't see so much post-stroke depressions as I used to do during the 90s. And I don't think it's that we are not attentive to it. It's rather that we have before, if the patient was sleeping and needed to sleep, we said, get up, you have to start exercising, and the patient had to adapt. And 1999, there was a meeting between doctors and psychologists when it comes to this kind of burnout, which was psychology, and fatigue-related depressions, which was more psychiatric. So the psychology field and psychiatric field crossed their hands, and I was involved in this kind of research, not on stroke patients, or brain injury patients, but ordinary people, work-related fatigue, work-related stress, and the impact on the brain due to that. And there was very few researchers then that had this plasticity perspective of brain when it comes to psychiatric symptoms. So I don't know if I really answered your question, but I think it's, for me, depression is a specific symptom that needs to be treated. Maybe if they show it, and when you treat it, you see effects not only when it comes to mood or the mood disorder, but you actually see it in the recovery of function.
So the question is then, with another question by Marco Galli, by treating depression, do you reduce fatigue? So can you bring to that conclusion, given your experience?
Yeah, so from a clinical point of view, if the patient has indications of some sort of mood disorder in the later stage, I start using an antidepressant to see whether that can improve the fatigue. And if I don't have an effect, I consider also central stimulating drugs, but with caution, of course. So already back in the 90s, I was using dopamine agonists, amphetamine even, to see whether it can somehow affect the fatigue. And I have not been treating so many post-stroke patients' fatigue with central stimulating drugs, but traumatic brain injury and encephalitis patients, especially tick-borne encephalitis that we see here in Sweden, using these kind of drugs, some patients, it improves the quality in cognitive functions, but it doesn't improve their buffer capacity related to fatigability. But then some patients, they also show an improved buffer capacity. So they are less fatigued, they have less fatigability. They can be active for a longer time compared to without the drug. But with stroke patients, we have to be very careful, as we all know, using these kind of drugs. But antidepressants is something that can be considered. And if they have a depression, yeah, it affects the fatigue for the patient. But using it primarily for fatigue post-stroke, just like that, no, it needs to be a clear indication using antidepressants, since they also lower the threshold for epileptic seizures, for instance. So one should be very careful using drugs, but it shouldn't be something that we totally disregard.
So Per,
wait, Paul.
Wait, I'm not.
A question from Adrian. No.
Oh, okay.
One last question. I don't know, Adrian, you're there. It was about neurogenesis. We have neurogenesis, but is there any that boost in neurogenesis, maybe during inflammation, post-inflammation, or during rehabilitation? I think it's a difficult question to answer, because to get this type of data in patients and humans is complicated, but I guess it's part of the also plasticity.
No, I mean, yeah, looking at many, I mean, there are there are these kind of huge studies that have shown that, yeah, stimulation is important in the recovery after post-stroke in the subacute phase, right? It has some sort of purpose in the recovery. Yes, that's the main conclusion after analyzing many studies. But still, so far, there is very little research that shows that we can improve recovery. And I think that is the first time I met an indication in that direction was the study that you have performed in Paul's group, where you have looked at specific stimulation relationship to non-specific stimulation. So because the problem with rehabilitation in the subacute phase has been that it's very difficult to have a control group in the subacute phase. That are not receiving stimulation. So the setup in using stimulation, but having the specific stimulation that is based on scientific theory compared to non-specific stimulation, that's the way to address these questions. But so far, when you see this recovery in the subacute phase, I mean, usually clinically, when you have stabilized the condition, you see this recovery, that the patient improves more or less. There's very little research that shows that we are actually affecting this. My view is, after 30 years in the field, is that we coach the patient in the recovery, but the brain recovers itself. We guide the patient in that process. Drugs might affect mood or something else that somehow pushes this recovery in the wrong way. So handling these kind of factors, yeah, then you have this recovery, which is very much spontaneous still, in my view.
So Paul, then thank you, Hamid. Paul, do you want
Okay,
to?
so Hamid, really thank you very much for a great talk. I enjoyed this, very informative. And it of course also raises some interesting questions, as always. And some of them, of course, we really want to track on them, like this whole link with affective state and so on, the link to also the training protocols you might follow. But the fatigue as such, we still lack a clear definition, right? Because indeed we have somatic components that we can speculate about, and we might even have functional components or even psychological components, like this link to depression, for instance. Now, so to try to disentangle that, does fatigue also correlate in the patients you looked at with, let's say, changes in the sleep-wake cycle or the sleep patterns, or for instance, with Belen, we have an interest in twitching. Would you see different kind of muscle twitching during sleep, or sleep spindle? So what can you say about the physiological correlate of fatigue and sleep?
I think that's very interesting, and going back to the image with all the explanations, the
Right.
glymphatic system, how is it affected in stroke patients? How does the transport of the metabolites, do you have an accumulation of metabolites locally that increases local inflammation in the tissue? We don't know, Paul. We don't know. But from a clinical point of view, working with patients, sometime when it relates to fatigability, if the patients pushes themselves beyond the threshold, it might affect sleep. And
right.
We know among stroke patients so sleep is fundamental. Sleep is fundamental, and there has been, but usually I think this is a very interesting question to address, also from a research point of view, because the sometimes patients, when you pass the threshold, when they pass, it might not be evident for them that they have increased symptoms. It might come later on, or it might even come the day after. So the baseline that I have described is not from day to day. We work with patients in trying to make them have this baseline for a whole week, Monday to Sunday. The dynamic changes depending on what they're doing, if they are returning to work or whatever. So it's so important to get this kind of baseline for them, and then little by little increasing it. So for instance, when they're back to 75% clinically, where I told you that you can make them push the threshold, and if they don't need to rest longer afterwards, because if they have not adapted, they can need to rest for 2 days or 3 days or a week afterwards. But if they only need to rest 20 minutes that they do when they have this kind of baseline, it's an indication that they have adapted and that they can can push the threshold. But the interesting thing is that if they are not sleeping, the quality of sleep is affected, so they feel tired when they wake up. That's an indication that they haven't adapted to that level. So you need to decrease the level of activity to improve sleep, because otherwise, if they get this kind of sleep disorder, it will not be sustainable in the long run, and they might actually turn out having mood disorders later on.
Yeah, but then would you say, Hamid, that we could use sleep patterns as a diagnostic on which to tune the training intensity? Would you see that as a reliable link?
It's one link, but I think that the main question now is, when we set up the for each patient individually, the extent of time should be depending on their how long they have this buffer, how long can they focus attention working with the RGS. If we push them beyond that, they will get tired, they will get unmotivated. If we push them much less, so if they have 20 minutes and they only can, and they are only provided with a protocol for 10 minutes, they will get bored. So this is the challenge, and you have this gamification setting in the RGS solution, and I still think that it's so interesting with the results that you already have.
Right. Okay.
Go back to that and see whether you get this kind of deterioration in function. In the results or in motor function, or this is maybe something that we can, depending on now the patients that we include in
I'm sure
RGS at Home project.
Belen will have some good ideas on that. Unfortunately, I have to escape now, Hamid. It was great to see you.
Okay.
and I'll catch you later. Thank you so much.
Thank you, everybody. Thank you very much.
No, but you go on discussing. I'm just, it's only me. I'm not important. Okay. I'm going.
Belen has a question. Belen, you pose it yourself.
Hello, Hamid. Hi. Thank you so much for the talk. It was a great talk, and we learned a lot about fatigue, because it was a long time we really wanted to understand better. So that's wonderful. Thank you so much. I've heard about a trial that is called Positive. I think it's not launched yet, but they're having this hypothesis that physical therapy or exercise counteracts fatigue. And they say that this explains variability in fatigue, physical therapy, and they think that actually you can lower fatigue if you give them exercise. But like, could you, or do you have any idea of what's the rationale behind this type of approach?
Well, working with different, not only brain injury patients, but also working with patients with burnout or fatigue related to fatigue depressions. What's so interesting is that the first phase of recovery of the buffer is physical capacity, physical activity, which somehow, this is my view from a clinical point of view, that if you don't have the body, if you don't have the regulation of the body intact, it's challenging for intellectual functions and emotions. But if you somehow can increase the buffer from a physical point of perspective, it can increase the intellectual and emotional buffer capacity. But there's a lot of other researchers also related to dementia and risk of dementia. So from a general point of view, physical activity is beneficial in many conditions.
Okay.
But when it comes to stroke, if you have an impaired function in your in a impaired arm or hand, I think the critical question is, if you have this kind of fatigability effect, to what extent should they be active? Where should you put the threshold, right? I think it's really a critical question, because with all the knowledge that we have today about stress, how stress affects plasticity, it might impair recovery. And doing big meta-analysis studies, I don't think that you can address this question, because you have some, we have to specifically address this. And I think that we have an opportunity with the RGS solution in actually applying, having patients included. Some of them, depending on which phase they are, if we have, without COVID, if we have time in getting them in the subacute phase, and having some patients push them beyond their threshold, keeping some at the threshold level, and some patients that they don't reach the threshold level, through that, I think we can learn much more related to intensity of rehabilitation. So, I mean, from a clinical point of view, working with these patients, when I tell the patients, how they should handle it, I tell them that you should be active, but you should be active within your coping capacity. But you can be as intensely active as you want within the coping capacity based on your fatigability. But so the vertical level, intensity level, they can increase that, but respect the threshold. So you don't provocate these symptoms, because if you get a mood, if you get sad, how long, or if you get pain, or if you get some other symptom, how long does it take until the brain has recovered? So usually some patients, they need to rest for half an hour, or they need to rest for 2 hours. They might need to sleep even. So, and also how to, I think that it's very interesting if we could somehow monitor EEG activity in rest, looking at EEG patterns or skin conductance in the rest phase, to look at the quality of rest also, and through that getting more of the biological view in the recovery. I think these are crucial questions for the future. Because when I'm stressed, I can be stressed. It can take me 2 hours to down, but I have a strategy. If I get stressed, I take a deep breath and I exhale, and then I hold my breath, exhale, and I count to 5, and I do that 5 times, and then I feel that my body gets calmer. Right? I have a strategy. But what strategies do stroke patients have? 80-year-old somebody with a post-stroke situation. I mean.
Yeah, thank you so much, Hamid. Thank you.
So do we have more questions? If not, that was very.
I have a question.
There is one question.
Sorry. Yeah, I wrote it in the chat. Yeah, first of all, thank you for the presentation. It was quite interesting, especially for me, because I'm interested in how things work at the system level, at the network level. And yeah, if I remember correctly, you mentioned that some of the regions where lesions correlated with fatigue were, for example, the prefrontal cortex, right? It was, I think, Schoenberger, exactly. And that's the anterior cingulate, right?
Yeah.
Basal ganglia, limbic area. So I believe these areas are also associated with motivation and reward, goal-oriented behavior. So I was wondering if, these functions, because there could be a relation to fatigue. And if you look at fatigability as how easily you get fatigued, could they also be related to motivation or reward-oriented behavior? And if talking at the network level, could lesions in these specific points lead to large-scale reorganization of these areas?
Absolutely. So just as an example, looking at attention, where the anterior cingulate cortex might be involved, and let's say motor attention. Like if you have a patient with hemiparesis, and when they walk, if the walk is automatic, it's not so demanding for them, right? So they don't get they don't get the same fatigue as a patient who has an impaired hemiparesis, where they need to focus attention while they're walking. If every step needs their attention, then they get you see this fatigability effect when it comes to physical activity, for instance. So this is why we need to be more specific in dissecting the different dimensions related to their coping capacity or their buffer capacity. It's just an example where they, because then they need to activate their anterior cingulate cortex with a motor function to compensate, and we don't know about the neck for works that have reorganized. But what we know is that the ipsilateral hemisphere somehow you see an increased activity in that part of the brain. We don't know whether it takes over function or whether they somehow strengthening the impaired function that has been affected by the lesion in the contralateral side. There are many questions still we need to address in a better or more appropriate way from a scientific point of view. And I think it's been disregarded in rehabilitation setting. Acute intervention, yeah, tremendous development, but rehabilitation, I mean, it's when I met Paul and the group in EBEC that I was impressed that shit, there are interesting things going on, and neuroscientific research now is reaching out to the clinical setting because it's been lacking, in my view.
Also,
I mean, from a system point of view, I mean, neuropsychology has been, I mean, developed for centuries, I mean, decades at least, based on lesion location. I mean, if you have a system perspective, we know it's much more complex. The location is just a node that maintains the network, and within the network, like a tent, you have the function. So you have dynamics. Yeah.
Yeah, also, Francisco, as Hamid said, that depression and fatigue are so different to disentangle. I think your question is very relevant for understanding that, because it seems that depression is very linked to some malfunction of those areas that you are pointing out, and especially the processing of reward. So I imagine that it must be very difficult to claim or to know that these reward processing disruption or alterations are related to fatigue instead of depression, right? Because I imagine these patients, like, it's very difficult to separate both. Am I right, Hamid?
No,
or maybe
no,
it's
no,
not?
no,
No,
no.
I'm not
yeah,
right.
yeah.
Okay.
No, no, no. I would say that it's clear. You can distinguish between fatigue and depression. Yes. You don't see the same mood. I mean, the challenge with depressions post-stroke also is that you have a lesion in the brain that affects. I mean, when DSM criteria was used for depression, the challenge was that organic psychiatry wasn't really addressing it, according to me, in an appropriate way. The challenge is that to fulfill all the criteria, but now in a setting, the fatigue, because at the same time, with depression you have fatigue. It's a common symptom within psychiatry as well. But the question is, do they measure it? Is it part of their pacing methodology in handling depression patients? So at least in this phase, I think it's very important to have fatigue as one of the parameters that you monitor, and also depression. But there is no correlation. From a clinical point of view, there is a difference between depression and fatigue. But in depressions, you can have fatigue, but you don't have the same mood affected within fatigue.
Okay.
And you know what I add to this question is not, since most people are assessing fatigue now, I think the interesting is to also to address fatigability where it's possible. So you don't get this kind of black and white, rather you have a dynamic and then you get some sort of deterioration of function.
So we have to address better, maybe in our scientific approach to rehabilitation, also how to measure these differences, no?
Yeah.
Disentangle the state of the mind with more, let's say, physiological, mechanical aspects of what stroke brings about. So they're very, very different things, but they happen at the same time within the same person. So maybe we have to be able, also with our technology, the way we are able to separate these two actions, the mind and the body, together. So we have more questions than we had before we started this this talk, but we have learned quite a bit. Also, thank you for taking us closer to the clinic.
Thank you.
I think if there are no more questions, I would like to thank you again and close this session. I hope you enjoyed it as well.
Thank you. Thank you very much for the opportunity. Thank you.
So thank you again, and
Bye-bye.
see you soon, everybody.
See you soon. Yeah.
Bye.
Bye.
Thank you, Hamid. Thank you so much.
you.
Bye-bye.
Thank you.
Thank you.
Thank you.